My name is Professor Damien Gruson. I am delighted to moderate this session today. First of all, I would like to thank the European Health Management Association for hosting the session. I would like to thank the Health First Europe for supporting the organization of this event. And we will have a session focusing on how artificial intelligence could transform cardiovascular disease management and care. We have a very nice panel of speakers today. I would like to thank them for their participation. This webinar is part of a series that we plan with the City Labs project. We put the emphasis on the space and role of artificial intelligence in the series of 2020. And we are convinced that artificial intelligence tools can provide some solution for the diagnosis and the treatment of cardiovascular disorders. Cardiovascular disorders remain the leading cause of death in Europe. More than 1.8 million deaths every year, which is about 40% of the deaths in the European Union. So there is a need to still improve the fight, the diagnosis, and the prevention for cardiovascular disorders. Artificial intelligence is in our daily life now, in many applications, also in the field of healthcare. And the development of the artificial intelligence technology is really rapid and accelerating over the past years or months. This webinar will be the opportunity to see the point of view from some very keynote speakers from different horizons. And we will take the question at the end of the session. So you could use the Zoom question chat to address your question, and please mention the speaker you want to address the question, and we will take your question at the end of the session. As first speaker, we are delighted to welcome Mrs. Maria Carvalho. She's a member of the Euro Parliament and co-chair of the MEP Art Group. She had several very important positions in the field of innovation. She was a senior advisor of the Commissioner for Research, Science and Innovation, Carlos Mudas, from November 2014 to December 2015. She was also a principal advisor of President Barroso in the field of science, higher education, innovation, research policy, energy, environment. So you have a lot of experience in the deployment and translation of innovation. Maria, thank you so much for being with us today, and I will give you the floor for your presentation.
Good morning. I hope that you are listen well. So first of all, thank you very much for the invitation to be with you in this important debate. And as it was said, one of the reasons that is so important is that the cardiovascular disease is the leading cause of death in Europe. And with all the development in areas such as artificial intelligence, we can do more to lower the number of diseases and to control better and to find prediction, diagnosis and treatment in a faster and better way. So fortunately, we have a rapid development of the AI technologies, and this can contribute to a lot of promising solutions, as AI is commonly refers to a combination of different technologies and fields of science, from machine learning techniques, robotics, combined with algorithms, automated decision-making system, which altogether can predict the behavior, the human behavior, but also machine behavior, and help us in the decision making, and make also autonomous decision. So, for example, AI can help a lot in the diagnosis, because it will be easier to analyze thousands of cases, thousands of indicators, instead of the typical. I'm not a medical doctor, but as I see when I'm a patient, then we have a traditional inspection and diagnosis. You are based in a limited number of indicators. With artificial intelligence, this number of indicators can be increased by an impressive number. And this will decrease drastically the percentage of wrong diagnosis when compared with the routine clinical practice that has been the most common practice until now. So if we use more AI, we can more accurately predict the heart diseases and optimized care. For example, there are other areas that are very important for for the cardiovascular diseases that are already very advanced in the use of AI. For example, the radiology, that is at the forefront of the healthcare sector, and it has helped the AI in the radiology as improved and enhanced the quality of the analysis and the knowledge that is acquired from other patients. So AI has a huge potential to provide solutions, to provide better diagnosis, better treatment, if we manage to tackle questions like the ethical principles and to have clear standards. So for this, we need to have what I usually call a strong AI ecosystem. And I put in this AI ecosystem the infrastructures, the skills. We need infrastructure and the high performance computing, because to analyze all this data, you need computer power. And sometimes not always, everywhere you have access to this computer power. You need skills, specialized skills, but you also need to have the medical doctors to have knowledge, not probably the specialized knowledge that you have in an AI engineer, but you need to have the notion how to use, how to communicate, how to work together with the AI specialists. So the medical doctors also need to acquire skills in this area. That is most of the time the case, but is not always. So they need to be familiar with this. And so infrastructure, skills, and last point, that is probably the most important, data. There are plenty of data around. There is no data yet in an organized way, in a large scale. We really need, and this is very important for the development of AI in general, but special for the development of AI in health and in each specific area of health. we need to have a health data space, in this case for the cardiovascular diseases. And is not only to have the data, but is to have in an organized way with standards and common standards, and with easy access by the academics, the researchers, the medical doctors that can have access to this data. And this should be done at European level, and even more than the European level, because the data that we have, the bigger the amount of data that we have access, the most accurate results and the most accurate conclusions. We have been in the European Parliament, a group of MEPs from ITRE, from INCO committee, fighting for this, for the creation of a real, very well organized European health data space that we think that will be very important, that it becomes a reality very soon. And what are the barriers for this, why this didn't happen yet, this well-organized, easy access European health data space? One of the difficulties is we still do not have a smooth way to apply the GDPR, so the questions of privacy. Individual, each of the medical doctors and the institutions, they know how to apply it, but it's not yet a generalized culture in a smooth way to apply GDPR. So this poses some difficulties to the space. Second is the fragmentation that we have in Europe. Health is still a national policy, is difficult to cooperate, is fortunately easy to cooperate at the research level, but when we talk more on the clinical area, on the exchange of data, we start having more difficulties. And there's also a question of insufficient infrastructures for all the health data storage. And again, lack of skills. So these barriers that are common not only to data, but in more general to AI, the lack of skills, the insufficient infrastructures, the difficulty of the application of the GDPR, and the fragmentation. We need to work, and fortunately the European Commission is working in each of them. In skills, there are an agenda for skills. We recognize in the European Parliament and also in the European Commission that is probably the biggest disadvantage that we have in Europe compared with other parts of the world, such as the US and Southeast Asia, that is the lack of skills in all the areas of information technology, artificial intelligence. We are lacking specialists on this area. Also, we have insufficient access to high-performance computing, and we have launched and we are already in the process to acquire large computers, and there is a private-public partnership under Horizon Europe that is foreseen and is already in the Parliament to be approved. And on the fragmentation, fortunately, we have given important steps in the last few weeks and even few days with the announcements from the President van der Leyen about the Union of Health with the new program, EU for Health, is a start. It's not as an ambitions that we like and we aim for, but it's a very important start. This is our president, probably because she's a medical doctor, and probably because also she's a woman, and she's more sensitive to certain issues related with in these areas. She had the courage to put together something that we have been, most of us, calling for, that is more cooperation in health between the member states. And now this is a reality. I'm very much optimistic that this is the beginning and is not going to stop here. We need to do more research together, not only in Horizon Europe, but to collaborate between the member states' research programs. They need really to cooperate, not only to be through the community method, but the intergovernmental method. We have to have the courage to put our big institutes of cardiovascular research, of cancer research, really working together. And we need more cooperation on the data, as I have explained, and I'm convinced that when more cooperation on research, we'll end up with more cooperation in the healthcare practice as it should be. So we are giving small steps, but this is the right way. And I'm very pleased that also the president has announced the Biomedical Research Agency. I have been called for that since I was rapporteur of Horizon 2020, was one of the amendments that we had. We shared that with many other colleagues that were supporting me. Unfortunately, we could not get it through. We had opposition from the council and even from the commission. The most that we got through was the scientific panel for health that put together many of the professionals, medical professionals, discussing the future and in certain way preparing the path to a more collaboration and to what is now the Biomedical Research Agency. So it was like the embryo for what is happening today. But already in 2011, we put in our Horizon 2020 this amendment. It was approved, was successful, approved in the Parliament. We didn't succeed at the time, but we left there something that after start growing, and now it's a reality. Of course, the situation of COVID has in a certain way pushed towards this cooperation, but we are very much pleased in the Parliament. We even very recently, before the announcement, I have written a letter with our former colleague, Mrs. de Sutter, that is now Vice Prime Minister of Belgium, exactly asking again President van der Leyen to create something of the sort of the BARDA, of this biomedical agency. So we have conditions to cooperate more, to do research together, from fundamental research to clinical research, to start on the best practice exchange between the member states in the clinical and healthcare practice, and to share data for the good of everyone, for a healthy Europe that we all aim at. Thank you very much for your attention and for your invitation.
Thank you so much, Mrs. Carvalho, for your words and presentation. We'll take the question at the end. It's my privilege now to introduce Professor Alan Fraser, an expert in the field of functional imaging of the heart. Professor Fraser is a consultant at the consultant cardiologist at the University Hospital of Wales in Cardiff. He's one of the famous face of the European Society of Cardiology, and he is chairing the Committee on Regulatory Affairs and represent the European Society of Cardiology on the European Commission Committee concerning medical devices. Alan, thank you so much for joining today. Floor is yours.
Thank you very much, Damien, and hello, everyone. Obviously, within the European Society of Cardiology and the Biomedical Alliance, we frequently discuss now issues of how we can use artificial intelligence appropriately. And I will reflect some of our joint discussions in my comments, but of course, I'm also speaking mainly from personal experience using machine learning in some studies and my personal views about where we should be using artificial intelligence and how we should use it. To me, there are very many opportunities now available to us, but equally some very important questions that I will touch upon. Firstly, let me just remind ourselves of the complexity of modern medicine. I won't go through this list in detail, but the genome has more than 3 billion base pairs. There are many microRNAs that are involved in translating the genome into proteins, at least 30,000 recognized. There are more than 2,000 human metabolic pathways, and we coexist and interact with a microbiome that actually has more bacteria than there are human cells in the average body. And of course, the microbiome can also influence the development of disease. So it's a huge and very complex system that is also influenced by environmental influences on genetic expression, age, gender, lifestyle, the fact that as we get older, most of us will have more than one disease or condition that affects our health. If you look at the recent ICD code, huge numbers of diseases, many of them extremely rare and therefore very difficult for anyone to know or be expert in more than a small proportion within one subspecialty. We also have large numbers of drugs, huge numbers of devices, and as we've heard from Maria Carvalho, diagnostic error is common. So this is the situation within which doctors now operate. And it's not surprising when we have that complexity and also now digital data from medical diagnostic imaging and diagnostic tests that methods have developed to cope with this amount of data. Artificial intelligence and machine learning are exploding in medicine. In this year alone, nearly 15,000 papers with one or other subject already published. Within cardiology, there are multiple applications that have been developed or are being developed, and I'm not going to go through these in detail, but they go from identifying new risk factors or biomarkers to better or more accurate methods for predicting risk of disease, to help us to acquire good diagnostic images and then automatically recognize or segment them and then measure their function. We can use such systems to look at cluster analysis to identify mechanisms of disease that may not have been suspected. We can indeed perhaps detect disease earlier and estimate probabilities of different outcomes. So we have the opportunity for more accurate diagnosis, leading to clinical decision support if appropriately used. And then, of course, we can also use these tools for better estimating prognosis. I'm not going to discuss many examples, but just let me show 3 or 4. Firstly, here is an example using data from 170,000 patients, looking at the prediction of a simple, clear endpoint, that is mortality at 5 years. And for cardiovascular disease, the best established risk factor has been from the Framingham study, but in this population it was 61% accurate, whereas incorporating measurements of function by echocardiographic imaging and developing predictive models using machine learning was very much more accurate, 89%. And the same difference applied to the subset of subjects with heart failure. And in this study, they were able to identify the factors that were used by the machine learning algorithm to perform this predictive model, which is useful for thinking about whether or not these can be modified. With diagnostic imaging on the left at the top, you will see 3 attempts to measure or identify the left ventricle and the left atrium for measurement of heart function. And you can see the significant variability between 3 individuals, whereas underneath here is an example of an automatically optimized image with automatic segmentation, identifying the wall of the left ventricle in blue, its cavity in green, and the left atrial cavity in red. And this can be much more reproducible and can improve quality. But we need to be careful about overestimating the performance of diagnostic tools such as this. This was a nice review on the right from last year, looking at studies where expert assessment and measurement of diagnostic images on the left had been compared with deep learning models on the right. And in fact, there was no significant difference. Overall, sensitivity and specificity 86 and 90 versus 87 and 92%. So in fact, what we have with machine learning may be more reproducible and more accurate, but not necessarily better performing as a diagnostic method, in fact, equivalent to current expert imaging analysis. And then one further example, looking now at 45,000 patients in a national heart failure registry in Sweden and estimating, again, survival, simple survival at 1 year, which tends to be done currently. We make our diagnosis of heart failure on the basis of the left ventricular ejection fraction. But you will see that in this registry, it did not discriminate between outcomes, whereas using a machine learning model, random forest modeling, identified 4 clusters with a differential mortality of 4.5 hazard ratio between the best surviving and the group with the highest mortality. Much better discrimination of different groups, allowing us perhaps to stop classifying heart failure on the basis of ejection fraction, which has led to a very differential availability of treatment for different reasons that I could discuss, but giving us the potential to manage this differently in future and to design research studies differently. But so far, there are very few studies that actually demonstrate a change in clinical outcomes. We're at an early stage of learning how to use these models. And there is a lot of hype. Here's one example from 3 years ago, suggesting that artificial intelligence predicts heart attacks better than doctors. But this was based on a particular study published here in PLOS ONE. And when you look at the data, you see that machine learning improved prediction indeed, but the established risk algorithm was 73% accurate, and the highest achieving neural network was 76%, and only a 3% difference. And indeed, a more conventional statistical technique of logistic regression was just as good as the machine learning. So in this particular study, the reporting in this example by NBC News was really inappropriate. It's not that different, and it's not that much better. And there are many people in all sectors considering the potential questions that we need to consider with how we apply artificial intelligence. For medical purposes, when we have big data, which indeed can be very valuable, we do need to remember that you can easily find chance correlations within very large data sets, nicely described in this book by Gary Smith. In the middle, I'm showing you an interesting book written by a lawyer asking if there are any decisions that artificial intelligence should not be allowed to take. And I think that's particularly important if we are using neural networks that are not yet interpretable, where clinicians and patients would not like to rely on a decision about treatment that is based on an algorithm that they cannot understand. And we also have the issue that we really haven't learned how to address, as identified in the final book on this slide by Stuart Russell, that if we entrust a lot of routine tasks to machines that are yet still under our control. We may not have the expertise to know whether or not they're performing properly. So for this discussion, we were set different questions: how we can use AI to tackle cardiovascular disease, to make a real difference, to implement AI solutions, and using AI to optimize outcomes. And actually, in my opinion, those are the wrong questions. AI itself is not an intrinsic good. It's a means to an end, and the end is more important. And the answer is not always AI. So we need to be a little bit guarded about how we use these and think of what is most important is how can we make a real difference and implement new methods of diagnosis and treatment that are effective and that improve outcomes. If you look, as in this summary from the ESC, at the burden of cardiovascular disease, as we've heard from Maria, a leading cause of mortality and premature death. But there are significant geographical inequalities between Eastern and Western Europe and between high and low income individuals. Now, will machine learning or artificial intelligence address that? Or are there social factors and behavioral factors that are much more important and that may need more attention? So AI is not necessarily the answer to all these pressing problems if we want to improve the quality of life. And here is an example of the vision of using artificial intelligence from a recent review in interventional cardiology, where you might have a very expensive and highly engineered robot that is semi-autonomous using machine learning and computer vision with an augmented reality system and an operator who might be able to have voice recognition software directing what the system is doing, and supported by clinical decision support, again, with components of artificial intelligence. Now, in the context of what I've just shown you, I think that raises huge questions. If we're doing that in 90-year-olds, it may not be most appropriate. So what we need, and we'll all agree on this, I'm sure, is an evidence-based approach. We need to set ourselves high standards of safety and efficacy for these tools when they're used in medical practice. And already there are professional reporting standards for trial protocols, for reporting trials that I've mentioned here from the Spirit and Consort consortia. And in particular, I would highlight their recommendation that machine learning code should be open access and any study should report and analyze its performance errors. And there are tools now to assess risk of bias. The regulators, of course, are also interested, but this is at an early stage and we don't yet have European recommendations on how appropriately to evaluate artificial intelligence within, for example, medical devices. But we've just recently been awarded a Horizon 2020 grant for a consortium called Core MD. And one of the tasks that we will be addressing after next spring is how to develop recommendations for evaluating AI within medical devices. So my last slide, a quick summary. I like to talk about augmented rather than artificial intelligence because our computers don't have consciousness. They would fail the Turing test. They're not really intelligent. They're just doing smart tasks set by smart engineers. So clinicians now need to understand the methods and we should be working with engineers to set the questions. But we do need much more research, highly critical evaluation instead of hype, and assessment particularly of whether these new methods have an impact on outcomes. And we must remember that the results of machine learning, as with other diagnostic methods, will vary by the population in which they're applied, by the population in which they were tested, and it's very difficult to do that with, for example, 6,000 rare diseases, and by whether or not we're using traditional diagnostic labels that may be imperfect. So we need very transparent methods of both interpreting and reporting performance, And like Maria, I agree we need legislative support for methods of sharing data with access to large curated data banks and imaging biobanks to improve the methods and compare different methods to identify which works best. Ultimately, though, we need to remember that we're not replacing clinical decision-making, we're supporting it. And we need to be very cautious about whether the tools that we are given are truly generalizable to different populations and age groups. And that means trust and transparency and open scientific reporting. Thank you very much. I look forward to the discussion.
Thank you very much, Alan, for these very stimulating talks and the important point that you raise. It's my pleasure now to welcome Birgit Beger for the next presentation. Birgit is the Chief Executive Officer of the European Heart Network, a network with a strong focus on the prevention of cardiovascular disease and stroke. She has a very impressive experience in public affairs, especially in Brussels, and she had an impressive track of record in the European health policy and federation management. She's a lawyer, and she holds masters in law and political science from the Free Universität Berlin. Guten Tag, Birgit. The floor is yours.
Bonjour, Damien. Merci. Yeah, good afternoon, everybody. Thank you for the invitation by CityLab and from the European Health Management Association to speak about artificial intelligence and cardiovascular disease. As Damien has mentioned, EHN is a Brussels-based alliance of foundation and associations throughout Europe dedicated to fighting heart disease and stroke and supporting patients throughout Europe. We have a big focus on prevention and the reduction of cardiovascular disease. We also look into advocacy, networking, capacity building, patient support, but also research, very important, as MEP Carvalho has mentioned, because we believe that there should be no longer a major cause of premature death and disability throughout Europe through cardiovascular disease. We are in the lucky position, or I'm in the lucky position for the presentation, that EHN has funded a research paper published in July this year on the value of digital tools for cardiovascular patients. So I will base myself very much on this study conducted by Martin Scherenberg, inter alia from the Heart Center in Hasselt and the University of Hasselt for Faculty of Medicine and Life Science. I have to confess that MEP Carvalho and Professor Fraser already mentioned a lot of applications of artificial intelligence, which our study also has highlighted. So I can a bit retract my presentation on aspects not so far mentioned, but it's good to see that the perspective is similar in politics and in science at the same time. So the evidence for the use of big data analytics is increasing. There's interesting usage for, as Professor Fraser mentioned, predictive risk models, but we can also go into pharma genomics. The diagnosis of electrocardiograms can be improved, image analysis, and of course, research can be facilitated. In a nutshell, these are all the advantages, and we also need, as mentioned, ethical considerations, because there's a lot of technology and a lot of innovation, but do we really harness it at a legal and ethical level, infrastructure as well? That is another question, and that is a task for us as a society to harness in order to be using it prudently. It's a tool, and as a tool, it should be understood. So what is also maybe interesting, and also again, it's two sides of a coin. You can use artificial intelligence also in order to identify trends or interpret genetic information, which again is very sensitive, but of course it gives a lot of knowledge vis-a-vis a particular disease. We can also link relevant data collected by different types of services providers, for example, that's more on a society level, social welfare, health and emergency care, and to get also better insight into the function of our healthcare system and see where are the gaps and where maybe disadvantaged people and groups are left out, and where health inequalities are produced also, where they lie. So this is another interesting or positive way of using artificial intelligence. There's of course the patient selection for clinical trials based on the profiling of the DNA. That so we have also biomarkers for targeted treatment. This is helpful for precise and personalized drug development. Could again reduce the cost of drug research, which is an important topic in our policy debate always. There's also one aspect that artificial intelligence could help to triage patients to the right care. That means based on the patient's medical history and current symptoms, the need to decide a doctor, which doctor, a specialist. So this is already starting to happening in some countries, but it is of course infant shoes, and again still needs to be improved. Yes, the development of new medicines with real added value could be fostered and potentially accelerated, and we could also detect new associations from the current available databases, and then new causal relationships could lead to development of new therapies or quicker diagnosis. Health analytics, the possibility of optimizing certain healthcare pathways. I've mentioned then what Professor Fraser has quite presented clearly regarding the predictive risk models. And what he also mentioned is, of course, the accuracy of radiologists and cardiologists in the interpretation of scans, CTs, echocardiography or MRIs. In the end, I agree fully with him that yes, artificial intelligence is a tool, is a means, but you need a professional with a training, a human brain behind it. It applies, of course, for medical doctors, but he also mentioned a lawyer writing it, and artificial intelligence is also used in law to search for cases and to find sources and to analyze how a case should be decided. But again, it needs a human brain behind it to control and harness it. So when we come to EHM's considerations from the patient perspective of all these wonderful elements, then I think increasing access to digital health technology and reducing pressure to buy the newest digital tools is also one element patients face. There is a financial pressure, but it's also the age pressure. Maybe not everybody is as savvy and capable as my 11-year-old son to manipulate electronic devices. That is the aspect of digital literacy, which should be coming with education. And this applies, of course, to patients, especially vulnerable and at-risk groups. But as MEP Cavallo mentioned, also the healthcare professionals need to be trained, and also, let's see, it needs to be integrated in a healthcare provision service. So it should not be a burden, further administration. It should be really a tool that helps to accelerate and improve healthcare services, and not another burden. So some of our patients say that the evidence for digital health interventions are not always given. So it is still true that seeing a doctor, having the possibility to have the patient-doctor relationship is of importance also today in these times. Then another legal question that we encounter a lot with in the healthcare system, and we've seen also with COVID, when telemedicine could help patients to avoid going to the hospital, and because they fear infections and the spread of COVID. So the use of telemedicine is good, but the question is, how is it reimbursed? The healthcare system does not always foresee that service provided through electronic means are reimbursed. And this is a decisive societal and economic factor for the implementation or the infrastructure, regulatory and ethical infrastructure, which we need in order to harness the advantages. Yeah, and that brings me to the last point, the lack of a uniform legal and ethical framework. We need a clear regulatory framework for the use of digital health and artificial intelligence. It's not there yet. This results in uncertainties, such as who is responsible also for decisions made by artificial intelligence systems, or who is responsible for data leakage when a remote monitoring system is hacked. So I think in this way we agree, the three speakers, that there is a lot of potential, but politically there are still challenges. But I'm also very much hopeful, as MEP Carvalho was, that COVID accelerates our perceptions and of what is needed within the healthcare system, so that the international research is coming together, the EU for health budgets, the international cooperation. Yes, at EU level we have the little nucleus, the European Patient Rights Directive, which already has some digital cooperation and has trans-border reference networks, etc. So that there is, the nucleus is already there for many years, but I think we should use the time now, having this heavy burden of the pandemic, to move forward in the direction of the EU for health, a closer join up of member states in order to assist their patients and their society in the best way. And this afternoon, maybe this is positive news, in my organization we have a research platform, and they try to develop it in a way that international within the EU, but also in a larger aspect, looking at the US and at the UK, that researchers can stay connected, develop joint research projects, and that, I think that is a wonderful development, and I hope with you all together and within all the experts together, we can indeed establish such a European Health Union, where we can bring policy forwards, helping cardiovascular patients, but a healthier society overall. Yeah, thank you for your attention, and I'm looking forward to the debate very much.
Thank you very much, Birgit, for your very interesting contribution. We will continue with our next speaker. Really delighted to welcome Ed Harding as a panelist today. Ed is the director of the Heart Failure Policy Network, and Ed is a key element in the development of multidisciplinary policy advocacy network in health. Is playing pivotal role to put competencies together. He has a lot of collaboration in healthcare, and is also a specialist at combining policy research as well as the engagement of the stakeholder efforts. Thanks a lot, Ed, for being with us today. I give you the floor now. Thank you very much.
Thank you very much, Damien, and also to Bridget, Alan, and Maria for having gone before me with some incredibly informative presentation. I much appreciate your introduction, Damien. It's very kind of you. What I can say is that we have certainly tried through a long-running project called the Heart Failure Policy Network to raise the policy profile of heart failure, and for very good reason. I'll talk more on that in a second. I'll let you all be the judge as to the difference we may have made. So with, I think, such well-informed and esteemed speakers before me, I will also not attempt, I think, to build on that. What I will speak about perhaps some of the questions from the broader systemic realities of how ready we are to optimize care in heart failure and the implications that this might have for AI as a game changer, as an innovative technology. And I'll be touching on some of our recent findings as part of that. So very briefly, we're a network, as I said, we've been around for 5 years. These are the endorsers of one of our recent reports, which gives a sense of our multidisciplinary nature. Patients, clinical leaders, NGOs, clinical centers of excellence have kindly supported our work and helped us to create the synthesis and analysis and the materials that we do. Ultimately, we exist to support HF advocates to make powerful case for change at the national, regional level. That's what we do. So what do we know about existing infrastructure systems in HF? I'm very interested to hear the presentations earlier, and I think some of the fascinating possibilities, but also challenges around AI in key points of HF care. Perhaps I could offering a perspective across the whole of the patient pathway. I'm sure everyone knows very well that heart failure is a complex chronic condition, or perhaps more accurately, a syndrome. It's something that heart failure patients have to learn to live with. It's incredibly challenging from psychological perspective and of physical symptoms as well, and it certainly can be challenging in terms of clinical management. That often has to go across different settings, from primary care into specialist care settings, outpatient settings, and basically patients are very commonly dropped, or guideline-based care suffers at key moments. And we know how to do a good job of this with disease management models. As with many chronic conditions, it's disease management programs that make the real difference. Here are some of the elements of them. But this, I think, gives us an interesting reflection on how might AI across this broader whole care pathway make the difference, and what's the reality check and what we already know. We already know that telemedicine, smart and remote platforms have a huge offer. There's some excellent trials, excellent studies done for various centers of excellence across Europe that show very, very good returns to patients in terms of reduced hospitalization, improved outcomes. So I think, although they don't necessarily bring in AI elements per se, I think they do show the huge potential to address key points in HF care where we get things wrong, and align the resources that we have in a much more effective way. None of this, again, I'm sure will surprise everyone on the call. I mean, we know that the whole, we're talking already about an interesting basket of ever evolving solutions in terms of telemedicine and smart tech and mobile apps, web-based tools, implantable devices, wearables. For those patients, I'm lucky enough to have perhaps some of these solutions in place. So then those have been very helpful through the COVID-19 pandemic. Of course, very many patients don't. And as we all know, I'm sure, a lot of the care flipped to telephone support during the COVID-19 crisis, which was the best that could be done in certain situations. But I think, as we were just hearing, for example, Birgit say, I mean, this has really brought to the front a focus on what it is that actually we need to more consistently hand out and give to patients in the community setting, if they're able to maximize their care through the use of technology-based solutions. So a huge opportunity, but again, as has been stated already, I think also by Alan, solutions are really just tools. I seem to quote my colleague here, Dr. Brito in Portugal. Whatever we're doing has to align, has to advance the broader package of care for HF management. That's the ultimate goal. What do we know about the realities of care and the degree to which health systems are prepared, both at policy level and at practice level, to deliver good practice in care? I've chosen a few data points that I think are relevant to this debate. For example, looking at IT and IT systems, including data and electronic health records, on the assumption that AI resources that are going to transform care over the whole care pathway must make use of such systems and must integrate into them and be part of data being shared between different settings, professionals, and the patients themselves. The issue, of course, is we know that actually there's a huge need to invest here. We do see some countries investing in collaborative IT systems, but really it's the exception, not the rule. The problem is that what we see across Europe is that IT platforms typically fail to collect the whole remit of clinical information required for HF and lack some key features in optimizing data sharing between healthcare professionals. And here's a good example of some of our findings from a recent report we've done. There are more in the report. I'll touch on that in a second, but as you can see, when you actually look into IT systems, even in countries that are, I think, relatively proud or on the front foot, shall we say, for example, in Denmark, we still see problem sharing data in IT. In some countries, such as Greece and Poland, we got very strong feedback from experts there that really the IT system remains completely inadequate and is one of the critical barriers. So I think for me, that's a bit of a reality check in terms of all being well, and if we can use AI to benefit the patient, the job that we have ahead of us in preparing HF care and the systems and structures that we need to maximize it. But I think, yeah, huge opportunities. I've picked a few other data points as well, because again, on the assumption that AI systems that help to predict and align resources in the most effective way to patients will be as good as the information that they get. Let's have a look at some of the information that we're able to obtain. And the key one of these, for example, is the NT-proBNP test, as we all probably, I'm sure colleagues will be aware. This is an HF guideline recommended test. It doesn't cost very much. It's of great use across the HF care pathway, not only at the point of diagnosis and ruling out heart failure, but also across the longer journey in terms of checking in on how well a patient's being managed and what their prognosis is. Unfortunately, what we know is that it's not very well nor consistently reimbursed across, for example, primary care settings in Europe. It's really quite patchy. And this, of course, is purely reimbursement. If we actually go into what's there in the literature and expert consensus about how it's actually used, that's also a problem as well. So again, I think a real reality check in terms of how we would maximize the potential of AI there through a one key test. Similarly, we would hope, wouldn't we, that AI systems would create meta reporting back to policymakers about effective interventions, just in the way that we currently expect national registries to do. But how good are we across Europe at bringing such data together and optimizing them at the sort of command level? Well, not very good. Only in England and Denmark have comprehensive mandatory registries on HF at the moment. Lots of countries don't. That's not to say that there aren't academic centers of excellence or multi-center studies doing a fantastic job at shining a light on what's going on, but it's not quite the same as a systemic audit that can really shine a light on inequalities and unjustified variations in care and patient outcomes. So again, I think quite a substantial challenge in my view as to the infrastructure that we would need. Which professionals at the primary care level or outpatient setting would be best placed to really work with AI systems to greatly improve the outputs that we get from the specialism and the resources that we have? Well, almost certainly, I would argue, HS specialist nurses who similarly already accelerate clinical expertise and do a fantastic job where they're available at coordinating different care. And virtually all of the most promising studies in terms of really reducing HF admissions and improving patient outcomes focus on HS specialist nurses. So the good news is 3 countries do formally accredit them, accreditation being pretty key for the systemic expansion of this role, but a lot of countries don't. And indeed, across the whole of Europe, we see quite a lot of systemic issues, workforce shortages, poor funding, and difficulties in referral. So we've got a really big challenge, I think, in thinking about the future workforce in heart failure as an example of CVD, as to how it would work with AI systems and achieve the best for patients. You would expect, wouldn't you, that I mean, given what we're describing, and I think a great deal of other challenges that I won't go into because we don't necessarily have time, it seems inconceivable to me that we'll find our way out of and plan our way out of this without very strong political leadership from the centre, a clear strategic vision of what we want to do, not least of some of the other issues that have been raised by speakers. Again, unfortunately, with the exception of England, where the NHS long-term plan has made some pretty decent commitments to HF, albeit dependent on local areas, we see a pretty mixed picture across Europe about strategic focus. It is improving. There are some green shoots, very promising signs, for example, in Spain and other countries, but we've really got a long way to go. So I'll stop there. We don't, again, it's a short presentation. It's just supposed to give a taste, I think, of some of the systemic infrastructure and political leadership issues that we face. I think there's a huge opportunity for AI, naturally. I'm sure many people do. If we can satisfy ethical issues, like any innovation, it only has to be as good, if not better, if we can help it scale. We've got brilliant evidence that we can expand disease management programs through telemedicine smart platforms. What would AI do? But as I said, I think there is a risk that there's a lack of systemic leadership, and that's going to hold back the potential unless that is also fixed. But I think, as with other elements, that there is a psychology of a game-changing technology and game-changing opportunities arising. I would say expanding, for example, NT-proBNP being one of those, whereby we really sort of switch on national leaders and decision makers to an exciting opportunity to achieve their goals. So I think AI has potential as well, political capital in activating leaders, as it were, to a problem that can be solved. Just very briefly, if you are interested in some of the reports I mentioned, do take a look at them. We're not hard to find. We're the HF Policy Network, and everything that we do is on our website or on Twitter. So thank you very much.
Thank you very much, Ed, for your very nice presentation and some very important point that you raised. We'll go forward and welcome our last speaker of today, Dr. Erik Ranskaert. Dr. Ranskaert is an active radiologist in the Elisabeth Twisteden Hospital in Tilburg, the Netherlands. Is really an innovator in the field of digitalization in radiology, and in 2000 he was co-founder of the arent Consult, one of the pioneering teleradiology companies in Europe. Erik, thanks a lot for your participation today, and I leave you the floor.
Thank you very much for your kind introduction, and I will just try to share my screen now. I hope this is working so that I can show my presentation. Just 1 second, I have to, yes. I hope this works now. Okay, so what I want to tell you, well, of course, I am radiologist, and I'm also president of the European Society of Medical Imaging Informatics, which is actually affiliated with the European Society of Radiology. And we, as a subspecialty society, we are focusing on all the new developments related to imaging informatics, including artificial intelligence. So this is also one of the reasons why I'm actually deeply involved in all the new changes that are taking place in our profession, and also regarding the implementation of artificial intelligence. So actually, for radiologists, there was a major, let's say, happening in 2016 regarding the development of deep learning. And deep learning is related, as you know, to image analysis. And actually, it was because of Geoffrey Hinton, who also won a prize with his algorithm in a competition. But he also made a statement, and the statement was that he said, like, the radiologist is like the coyote that's already over the edge of the cliff but hasn't yet looked down. And so this is a man who also won the Turing Award in 2018. So this really shook up the radiological community. So what we saw is that there was a really growing interest in artificial intelligence among radiologists. And as you see, I have been speaking here for the European Society of Radiology. I also won This is the first book, by the way, that was published on artificial intelligence in medical imaging, and I'm one of the co-editors. So the book is still available, of course. It was the first book on AI in medical imaging. And as you can see, there was also a new journal coming up from radiology, which is the reference journal in radiology. Now the electronic version. Artificial intelligence is completely new. So as you can see, what I wanted to show here is that there was suddenly an explosion in interest in artificial intelligence for medical imaging, even in major congresses and meetings like the RSNA meeting, which takes place in Chicago every year. So actually also by these new developments, some kind of an AI bubble was created. So there was a lot of hype about AI in the media as well. And this caused an inflation of misconceptions, namely that radiologists would be replaced by robots and artificial intelligence. It also created some fear among students, even among radiologists, about the future of their profession. And actually, this also created some unrealistic expectations in AI from both the physician side and the patient side. So, but nevertheless, our profession is facing a disrupting change in the upcoming years. That is a fact. And why is AI so relevant for imaging? Because, well, actually radiology is producing a lot of images. And this is why also we are in the lead of AI, because we can do something with these images. This is all digital information. And as I said already, the interest is growing exponentially, not only in scientific publications, but also in professional meetings, etc. And we see that the implementation of AI applications is growing steadily, but slowly. The number of companies offering tools in AI is growing enormously. And well, it's not only, they are not only spin-offs from academy, but we see all kinds of new developments as well in that area. Most developments are taking place in the United States, but Europe is kind of a mosaic of countries that initiatives in AI. So we are, let's say, to the outside world, we are not as a united group. We are not like China, or we are not like the US. We are separate unities, all doing several initiatives. And also what is important is that if hospitals want to implement AI, they really need a local champion that are willing to do this, that know what's going on, and that have the, let's say, the drive to do this. And I will talk about this push versus pull model in hospitals in a further slide. But actually, what role does AI have now in imaging? Well, first, these are the main purposes. It's detection and diagnosis of diseases. It's the disease severity monitoring. For example, how is a disease evolving during therapy? And AI will also help us in predicting the outcome of a treatment. This is just an example. For COVID-19, for example, AI was developed to detect the abnormalities on a chest X-ray. The chest X-ray is still the most common radiological examination that you can imagine. And this is also being used for detecting COVID-19 disease in patients. So also algorithms are developed to do this, and this can even be implemented in areas where there's no radiologist available, such as in developing countries, for example. There are a lot of new other areas where AI is being developed, for example, here for detecting breast cancer, for detecting brain abnormalities, for airway abnormalities, for the retina. This is for ophthalmology, for eye diseases, of course. This is for the prostate. Tools are being developed to detect prostate cancer, the lung diseases. We have even dermatology, this is dermatology, and we have pathology. So the AI tools that have been developed are pretty accurate in detecting cancer in lymph nodes, for example. So these are just to show you that AI is gaining importance in different specialties, not only radiologists, but also in others, and usually in specialties that are related to image creation or imaging. There is a rather slow adoption of AI in radiology, as you can see here, and this is due to several factors. First of all, there is still, you can see in the hospital, there's still a lack of insight into current workflows. How are these workflows being organized, and how can we use AI in these workflows? There is also a lack of trust by medical specialists to to the development of AI solutions in isolation and usually by non-medical doctors. So there is still a gap between the developers of software and the users of software. And there's also, and this is very important, still a main lack of access to high quality data, multi-centric data, not only for developing algorithms, but also to validate them. So this generally leads, or this often can lead to models with average capabilities. And actually what is also important is the fact that there is a lack of algorithms that are specifically optimized for healthcare specialists in specific conditions. Now, as you can see here, radiologists have been active actually also for developing algorithms in the COVID-19 disease. And so they are not waiting, they are actively engaging in developing tools that are needed, which is quite important. Nevertheless, there are still challenges in developing these tools because, well, it's possible that the data collected in a pandemic are biased. And the question is also, how can we generalize these tools that are being developed? And how can we clinically deploy them when used in actual patient care? And the question is also, do we have high quality data? So there's several challenges. We can also see that organizations are making databases to collect data from, and this is the COVID-19 pandemic was a good initiative to do this. We saw several projects that are being launched. Now, the awareness, and this is now I'm talking from my own experience in my hospital, when you want to implement AI, it's very important to create awareness, and you need to talk to a lot of people. You need to talk to the managers, to the board of directors, to all the stakeholders, the ICT department, etc. So what you really need in a hospital is a common vision. And of course, initiatives in this area come from several users in the hospital, but you have to coordinate all these initiatives. And this is also what we are doing. For example, we are looking for other expertise outside of the hospital. We're now working in collaboration with the University of Tilburg. They have the computer scientists there. So we are looking for ways to do some things together. What also is needed in the hospital is to create standard procedures. If you want to implement an AI tool, it's new for everybody to do this. But what we see is that we are struggling every time with the same hurdles when we want to implement a new tool. So you have to standardize these processes of implementing tools. Of course, you have to think about budgeting. What can we invest? How should we invest it? What's the return on investment? And which is also very important, in my opinion, is the education. When you have radiologists or other specialists in training, you also have to create awareness among them and learn them about the basics and the techniques of AI. How can we use it, and what are the pitfalls in using it? And of course, ideally, we should look for collaboration with other hospitals and even the academy to share data. To give you one example of what we are doing, we are developing an algorithm for a CT scan of the total body that is being done for patients with the multiple myeloma or the disease of color. So what we do is develop an algorithm to detect all these holes in the skeleton. So this will help us in detecting timely the right abnormalities in the right patients. So this is what we are doing now in collaboration with the Tilburg University, and we do have funding for that. We are also actively engaging in a European project for COVID-19 to analyze abnormalities on CT scans of the chest. And we are doing this together with my society and with a lot of other European hospitals. You can see we are obtaining data from all over Europe. So again, to show you how a pandemic situation can be an initiative or a trigger to collaborate with other hospitals throughout Europe. And this is actually the ideal way to make data available. But still, we see that in Europe, there's a lot of hurdles that need to be taken regarding patient security, patient safety, GDPR regulations. So you really need a very solid research agreement, a contract. And this is not easy to obtain this kind of agreements in every hospital. So implementation of AI in the hospital, well, actually the first thing every hospital should do is define the most meaningful use cases. What can we do with it? Where could we use it? And then we have to communicate it with all the stakeholders and the decision makers in the hospital. We also have to study what kind of equipment do you have, what kind of infrastructure do you have, how can we integrate everything. So you have to make a roadmap for every project. You have to calculate costs and find budget. actually what is also necessary is a project manager so that you can do it in an organized way. And you can even, let's say, you should also make key performance indicators to evaluate how a tool is doing. And actually this needs time. Just to show you how many stakeholders are involved in this process. I mean, it's not only the Department of Radiology, it's the ICT, it's a data warehouse, it's the clinical physicist, it's the referring physicians, it's the teaching, the scientific office, it's the board of directors, DPO, data privacy officer, it's a sales department, etc., and all the vendors. So you have to integrate and organize the communication. I'm not going to go further into this, but on the long term, the question is also what kind of model will prevail in radiology? What kind of commercial model will prevail? This is the push versus the pull model. What is the most relevant model to implement AI? Will we be forced to use it, or can we do it ourselves and pull it in? How can we integrate our data that we have, not only the images, but also the patient data from the electronic patient record? How can we do this? We have to think about this. How can we adapt our infrastructure? We have to find ways to collaborate with the data warehouse. Of course, if we want to achieve the ideal situation of personalized medicine, this is necessary to integrate all data. We have to be able to make decisions based upon imaging, including other data. And we have to invest in the infrastructure. So this is a long-term vision we have to adhere to. Of course, ideally, we should be able to facilitate the sharing of data among hospitals. So we have to find secure solutions to do that, or maybe alternatives to do so. And the importance of education to finalize, this ends up about, well, this ends up being about trust in the development of methods, data, and metrics, as well as the outcomes. So all stakeholders will be increasingly faced with these kind of decisions, and we have to be able to trust the algorithms, and we have to know how to interpret the models. And it's more important than ever now that the education in the fundamentals and the principles of machine learning and for all those involved is crucial. So I thank you for your attention.
Thanks a lot, Eric. Thank you very much for your very nice presentation and for the illustration in the field of radiology. We are running short in time. Unfortunately, it's already 1:30. The time is really running too fast when you have brilliant speakers. So I would like to thank again all our speakers for the great talk today, the key messages they deliver. We are on the way to have efficient AI translation to support cardiovascular disorders, diagnosis and management. So thank you very much for your participation today. Thanks for the attendees, and I would like to thank again the EHMA and the HFE teams for making it happen. So wishing you all good afternoon. Take care, stay safe in this COVID time, and see you next time for our next educational activity. Thank you very much.
Thank you. Have a good afternoon.
Bye-bye.
Bye-bye.
Thank you. Bye.